Good afternoon, everybody. I am Dr. Srinivasa Kumar Ravipati, Senior Consultant, Transplant Pulmonology, KIMS Heart Lung Transplant Institute. So today we are going to discuss about the long COVID syndrome. So the main purpose of this discussion is after the discharge from the hospital, many patients still be having these symptoms which are lingering associated with the COVID or the sequelae of the COVID. So this can be distressing to the patients, but everyone else may be saying that, okay, you have gone through a lot, now you are fine, you just lead your normal life. But even the symptoms are very small or minimal, as long as they are persistent, they are continuing, it can cause a significant impact on the lifestyle. But at the same time, not many of these symptoms are worrying or very severe or not concerning. So in many times it just needs to be reassured and let them know that it is something that's very it's a casual, it will happen, we just have to deal with it, live with it, and slowly it will fade away. So the main focus today would be to tell when to concern, when to worry about these symptoms, when not to worry about the particular symptoms. So if you see the term long COVID syndrome, this term is actually coined by a patient, not the doctor. In the beginning, we also thought once the COVID hits, patient got admitted or can be treated at home. Once this is over, maybe in 2 weeks, 3 weeks, 4 weeks, 5 weeks, then the things would be mostly okay. But then one or the very few of the patients would be feeling these symptoms persistently, and one of them is called, this doesn't seem to be COVID, it seems like a long COVID because I've been suffering with this for a long time. And that's how this term has been coined. Then we realized, the medical fraternity also realized, yes, there is a can be significant impact even after the acute symptoms are treated in hospital or outside hospital. So there are quite a few research and surveys has been done to look into this fact. So the surveys showed that approximately 40 to 60% of the patients in various different surveys will be having these persistent symptoms. And the most common of those symptoms would be the weakness and fatigue, followed by the insomnia. And when we survey it further, about 40-45% of these particular subset of the patients are told that their symptoms or the concerns are not being addressed properly by the medical fraternity. This is something we ourselves look into it and work along with the patients to fix this issue and to support the patients in a way that we can do. So that is the main purpose today. So we define what is actually the long COVID. Then we'll go into the details, what causes it, how to prevent it, how to diagnose it, and how to treat that. See, when someone got the COVID first, they'll have acute symptoms like, as you all know, the fever, cough, chest pain, loss of smell, all those things can happen. And sometimes and most people, they be okay and they may not need the oxygen. With these symptoms or without these symptoms, they can come through the patients who has a persistent fever and whose oxygen is low, they need admission and they need oxygen support. Some percentage of these people will need a high oxygen support, and some would need a ventilatory support, and some would need a ECMO support. There's a little fraction of the people, but the problem with the COVID is because it affected crores of people in a short span of time. However small this percentage of the people, they became big in number. So if you see the first day 1 to 4 weeks, we call it as acute COVID. So up to approximately 1 month, we call it as acute COVID. So after 1 month, after 4 weeks, if someone is still having these symptoms, then we call it as a long COVID syndrome. we can divide it into two further this thing. Up to 3 months, like up to 12 weeks, we call it as a ongoing symptomatic COVID. After 12 weeks also, if the patient is experiencing these symptoms, then we call it as a post-COVID syndrome. So it is as simple as that. Initial one is the acute, and then they're still having these issues. That's why we call it as ongoing symptoms. After 3 months also, because by 3 months, by 12 weeks, most of these symptoms should settle. If they're still experiencing this, then we call it as a post-COVID syndrome. So if you look into these patients, so there is quite a few surveys which are seen, like UK is one of the survey which has a good number of patients that's been included. They have observed that in the discharged patients, the patients who got COVID, who needed a hospital admission after their discharge, if you compare with the patients who have been discharged for other reasons, these particular subset of patients will be needing like 3 times more frequent of readmission rate after the discharge for some or other reasons. And they have a 3 times more prone for the heart related problems, and they have 21 times more prone for the respiratory or chest related or lung related problems. So the patients who have been discharged, who needs high oxygen support or the ventilator, they may still have significant issues even after the discharge. This is a significant number, and we need to closely follow them. So why it happens? There could be 3 or 4 different reasons. The common one is the direct damage done by the virus or our immunity. The second one is the inflammation, the ongoing inflammation process. So the natural the way that our body reacts is when the virus or any other pathogen means any bacteria or virus that can cause infection to our body, when it enters the body, it triggers the immunity. So the immune cells recognizes these, and then they'll decide, okay, this can cause harm to our body, so we have to fight against it, destroy it. Then they will deliver some particular cells, and which can release some chemicals, and along with these cells directly can destroy the virus, or the support of these chemicals it can destroy the virus or the bacteria. But what in COVID, what we have observed is this immunity, which is supposed to protect, sometimes can overreact. So can cause more number of cells than required to that particular area, and can deliver more quantity of the chemicals than required. Because of this, there can be a collateral damage, and this can cause either direct damage or indirect damage to our different systems, depending on where it happened. And most common site is the lung. So that's ongoing inflammation. So ongoing inflammation, if it happens inside the blood vessels, so it can damage the lining of the blood vessel, which can further lead to the clotting inside the blood vessel or gangrenes to the peripheries. So we have observed quite a number of patients who've been having these issues, the clots. The clot, depending on where the clot forms, again, it can cause significant impact on there. So if the clot forms in the brain, they can come with strokes or mini strokes. If the clot forms the blood supply to the kidneys, it can cause kidney damage. Most importantly, if the small clots forms, the small blood vessels which supply to the heart itself, it can cause heart attacks. So these things, this all can happen because of the ongoing inflammation of the blood vessels. If the ongoing inflammation of the neurons or the nerve cells happens, then it can cause neurological issues. So that is one aspect of it. And the third one, what we now commonly observed, is autoimmunity. So we see this is the virus is acting as a trigger because it is triggering the immune response quite abnormally. Because of that, there are quite a few immune cells are releasing. It starts affecting the other systems, like a multi-system disorders is happening. This is what we observed and very well documented. So they can develop the rashes, they can develop the muscle pain, they can develop the joint pains. If you see from the before, like a chikungunya is like a very well known this thing for us. After they had this chikungunya, we have noticed lot of these patients will be having the joint pains. So there is no direct relation between these two, but still we have observed that. The reason behind is the same principle, because it is a immunity is a dysregulation of the immunity. The similar way in COVID, the immunity is either dysregulated or hyper responsive, and that's what causing majority of the issues. So if you see which kind of patients are more prone for these long COVID symptoms. So if the patients are elderly or more than 50 years of age, they are more prone. Females especially are more prone if you looking at the sex disparity. And if they are having any comorbidities before, like diabetes, hypertension, BP, high BP, or they have any kidney problems, or there are any other immune suppressant medication for any reason, all these a subset of patients have a higher chance of this long COVID. And the similarly, if they are having severe clinical condition with COVID, so if someone is discharged, just little bit of symptoms, maybe 1 liter, 2 liter oxygen, and they discharge, then the chances for them to have this long COVID is less. If someone is requiring high oxygen, non-invasive ventilator, like a mask, high flow oxygen, then they have a higher chance. And at the same time, the patients who needed to use the steroids or the high dose steroids for whatever the reason, they are also having the higher chance of these long COVID symptoms. So if you see there is a recent article that is published in Natural Journal. These symptoms could be even after 6 months also they have noticed, and most common one is the shortness of breath. So you feel short of breath, you feel as if the breath is not enough, you still require, and cough. Dry cough, most people will be complaining for quite significant number of weeks after that. And the most common symptom, as I told earlier, is the fatigue and muscle weakness. They feel so tired, they could not do their routine things, they don't feel like going back to office, all that. And in some cases we even suspect them that they are thinking like psychologically they are affected, but it's not that. It is actually physically they feel this weakness and all. So all they need is understand their concern, support, and enroll them in the rehabilitation, and take them adequate hydration. If they don't have a significant heart or kidney problems, they can take plenty of water, vegetables, yoga, all these relaxation techniques. With all that, slowly it will improve. And the other issue that we have observed is the sleeplessness. So many people won't get sleep after that. Technically we call it as insomnia. That is another important observation that we have noticed. And anxiety, because of the too much of awareness about the COVID and too much of info about the COVID also can sometimes putting the pressure on the patients. So they will be thinking always the worst, and that causes a lot of anxiety and worry and concerns. And these things need to be addressed as early as possible, and they should get the proper guidance to help. So if you see different systems that we have seen, which way it will affect. So if the post-COVID or long COVID can affect multiple systems, starting from the brain to the toes. So if you look at the neurological, as I mentioned, all this anxiety, sleeplessness, all this, they have a technical reasons why it happens, and they can the calm environment, supportive environment, or if you still need some melatonin substrate, it can help to improve the sleep. So if anyone is feeling that, please do contact your physician and let them know that what exactly is causing an issues with your day-to-day life, and they will fix it for you. If you come to the lung, which is the most common organ that getting affected by the COVID, because of the nature of the way the infection happens. In most patients, it will resolve without causing much problem to the lung, but we have seen significant number of patients who is having this fibrosis, the scarring of the lung. As I explained earlier, this is probably due to dysregulation of the immunity, and this is a collateral damage, because lung being very soft and supple, it should be like a sponge. But when this inflammation, significant inflammation more than what is required happens, it causes the damage to these soft tissues, and it will become very thick. When the lung tissue has become thick, then it acts as a barrier for the oxygen to cross and the carbon dioxide to cross. So normally the function of the lung would be, when we take the air in, the air will take the oxygen and it will enter in these small units of the lung, which we call it as alveoli. When it reaches there, the oxygen will go from the lung into the blood vessel, and the carbon dioxide which produces in the body will cross from the blood vessel into the lung, and then it will come out. So this is how it should happen. Why we need oxygen all the time? Every cell in our body to live, they need a ATP. It is an energy molecule. How do they produce those molecules? By utilizing this oxygen. When this oxygen doesn't reach to that particular tissue or the organ or the part of the body, then within few minutes it can cause damage. And that is why it is very, very, very important for the lung and heart to work in synchrony. The lung will give the oxygen to the blood, and heart will pump the oxygen across the body for every organ in the body. So that's why they should work in synchrony with each other. So when this doesn't work because of this thickness, scarring, or the fibrosis in the lung, the body doesn't get enough oxygen. So that is the main reason. Even in acute COVID, what happens? So what we are doing, we are giving more oxygen or supplementing with non-invasive ventilation or the ventilator, putting more pressure and more oxygen to increase the oxygen in the body. So after this 3-4 weeks are over, most of the time the lung will recover to the reasonable extent, but some will be having significant fibrosis even after that. Then they will become dependent on the oxygen. So if it is a small like a 2, 3, 4 liters, then we can continue with the oxygen. Over the span of months, weeks to months, they will slowly improve. But it will take a longer time, or if they are needing significantly higher oxygen requirement, then we need to evaluate them closely, see to what extent this scarring happens, and we need to see the further modalities of the support. So that is one. Second one, because of this, as I told before, the blood vessels can be more thrombogenic, which means they are more prone to form a clots inside. So if the blood vessel which support the lung, if they develop any clots inside, which we call it as pulmonary embolism, then it can cause a significant problem, because there is no blood flow to the lung, and there is no oxygen, not much oxygen that enters into the blood, because there is not sufficient blood which flows to the lung because of the clots that blocks the flow of the blood. So that need to be treated immediately. So we need to look for that as well. The other things that we have noticed recently, especially in our country, in India, is the mucormycosis. It can happen in the lung, or it can happen in the sinuses next to the nose. So most of these patients will be presenting with either persistent cough, headache, or visual disturbances, which means disturbances in your vision. You cannot see it properly. So why it happens? When the COVID itself, your immunity will be low. On top of that, unfortunately, with the way the disease works, we are forced to use the steroids in some patients. Some will take a longer time on that, some will need a little higher dose of it. All this can cause very low immunity in the body. So this will be like will become the fertile land for these the fungal growth. So once they enter these sinuses, they can grow rapidly and cause local destruction in that area. Can be very devastating at times. So we need to address it very seriously and immediately. And now that there is a lot of awareness about it, it's been happening. So if, so that is something as significant as. So we are talking about the worst case scenarios here. It's not that many patients will get it. This is something, if any of these symptoms that we observe, it is better to get the clinical advice early possible. But very few patients will only get this. So don't worry. But if you do any signs of it, better to just any symptoms of it, better to get a clinical advice. And the other next issues would be if you look at the heart. So they can develop the heart attacks or mild heart attacks. And another interesting observation that we have noticed is the heart goes very fast. Medically we call it as tachycardia. So continuously the heart will go in fast, like 90, 95, 100, like that. This can happen because of the nerves that supply that controls the heart rate can get deranged sometimes with this COVID inflammation, and that's causing this very fast heart rate in most scenarios. And some would be needing like a low BP. If they suddenly stand up, their BP will fall down, and then they feel like a reeling sensation as if they are going to fall. So if you do experience any of those things, the best way to do is give time for the body to adapt to it. So don't suddenly stand from the sitting position. You take time, first slowly 45 degrees, then little bit more, then you can stand upright. In that way, the body slowly adapts to the change in the position, so that the BP will not fall rapidly. The next issue that we have noticed is the GI symptoms. Many patients will be having these either sickness, they feel like vomiting, they don't feel like having food, and belchings, and these gastritis symptoms. All these can happen, and some will be having this. They have to go for the toilet for 2-3 times, and even after they had any food or anything to eat, immediately they feel like going to the toilet. All these things can happen, but they can improve slowly. If it is not, and if it is causing persistent issues, need an advice from the specialist gastroenterologist. So other issues that we discussed as a multi-system inflammatory syndrome. So these inflammation is a multi-system. There will be joints can be swollen. They will have a arthritis kind of picture, and they'll have a pain in most of the small joints or some of the large joints also at times. So these things, and the rash, skin rash, and they can't open the mouth properly. It will all become stiff. The skin will become stiff. So these things can happen in very small subset of patients. So if any of those, then they need a rheumatologist advice in that aspect, and they would need a prompt treatment. And the interesting part is these things, most of these symptoms, if we notice early, if we do intervene them and give appropriate treatment, and they will improve significantly, and most patients will be normal within a few weeks of the appropriate treatment for those. So these are the different issues. Then if you see the clots in the legs, if you see the clots, then we have to give the blood thinning medications. when we use these blood thinning medications, you have to take little bit more care, avoid any injuries, because the blood is too thin sometimes. If it starts bleeding, it can bleed more. So avoid any injuries and be careful yourself. But you can do all the works, but little care with the sharp objects when you are using, and avoid, if anyone has a history of falls or prone for falls, has to take more care to avoid the falls. So these are the most common symptoms that we see. So how do we diagnose these things? Again, it all depends on what kind of symptoms we have, and then we have to evaluate those. If the problems are with the lung most, then the important thing we need to see is the oxygen saturations, how much oxygen is maintained. Most people would be okay when they are sitting in not doing anything, but we also need to see how much oxygen they are holding when they walk. So we see it as a 6-minute walk test. So we ask the patient to walk for a 6 minutes, come back, and while walking we observe what's their oxygen levels. After the walking is over, when they are at rest, we observe their oxygen level. So most of these will be the subset that we are having issues with scarring and fibrosis. They will have the low oxygen levels when they are doing something. So one important aspect at home, what we do is, though if we have a pulse oximetry, the patient will go to the toilet, then he will come back and he will say like, I am very short of breath, and the family checks the pulse oximeter at that time, then its saturations may be okay. But when he is going to the toilet, or when he is doing some work, or when he is walking, his oxygen might be low, and that's what causing him shortness of breath. So that is we need to look into that and understand their problem clearly. So that is one test that we normally do. And then if we are suspecting any kind of infection or significant fibrosis, I think we repeat the CT test and we compare with the previous one, see how it is, and depending on what it shows, we plan for the treatment. And so we have right now the quite significant patients on ECMO as well, and many of them we even tried to wean off from ECMO, and not many are coming out in that particular very small subset of these patients. But being a referral quaternary care center, so we get all these patients after every other options are exhausted in their own their respective hospitals and territories. So once we try to wean off them they from the ECMO, if we are still not able to do, then the only option that left with us is the lung transplant to consider. And some patients who have a significant fibrosis after the COVID, who are requiring high flow oxygen even after a few months, then in those patients also at some point of time we may need to consider this option. But this is the option we will explore only if everything else is tried and not worked, and this is the only option that left over with. Okay. So the similar way in the heart, so if there's having these persistent symptoms, please do contact the cardiologist. They will evaluate, they see your heart rate and over the 24 hours how it is happening, and they may do the angiogram to look is there any clots inside that is causing, echocardiogram which looked at the ultrasound windows of the heart, and depending on the findings we'll tailor-made the treatment. And similar way, kidneys, very few will be having less urine and some will be having more urine. So either of it is not good. So we have to watch it carefully to see and find out the reason that's causing this, and the nephrologist or the physician would advise what best to do if that is existing. GI symptoms, gastro symptoms, as we discussed, mostly they will settle over the span of time, but they may need little bit of intervention like to antacid medication, and the PPI we call it as these medicines to reduce the acidity, and also some irritable bowel some people will be having, and that, and most importantly this anxiety, depression, and all other these things would need a psychological counseling, not necessarily the psychiatrist, even the good counselor is best, if you noticed, if because it just needs to be listened to them, understand their problem, and try to give a perspective and our opinion, and which can soothe their concerns and worries. So that is also very important. In our busy life, most of the times we miss this. So because we, if one of our family members got affected with this, we already lost significant time spending with the hospital and all. Then once they come out of the hospital, we wanted to go to our routine work as early as possible. So with other demands, financial, economical, all other aspects also forced us to do. So we will leave them and then we will go to attend our job and duties. But they will not have time for someone to listen to their concerns and all. This needs to be addressed as well. It is good if someone actually listen to them, understand their fears, worries, and clarify their concerns. So these are the broad spectrum of the things that we normally see in the post-COVID syndrome or long COVID syndrome. And many patients will be asking about the vaccination as well, when to take, when not to take. So the recent guidelines suggest that once the patient get discharged, 3 months after that, if they are not taken the vaccine before, they can start taking the vaccine. If they have taken 1 dose of vaccine before, then they can take the 2nd dose of vaccine. So that is usually the 3 months after their acute symptoms resolve, and then they get discharged from the hospital.